All right, Amanda Bryant. Chris Clark. Bruce Davis.
Present. Here.
Diane Fleet.
Here.
Janice James is excused. T.C. Johnson. Kathy Plowman. Bo Revlett. Here. Liz Sheehan.
Here.
Alicia Branham.
Here.
And Lola Still.
Here.
So we do have a quorum. Next on our agenda will be the approval of the November 8th meeting minutes. Would there be any revisions required? All right. Hearing none, do I have a motion to approve? This would be a board vote.
I move approval of the November 8th meeting minutes.
Thank you, Bruce. Do I have a second?
I second that motion.
And I'm sorry, who was that?
Me.
Thank you. I was looking too many places at once. All right. Now for a vote of the board to approve the November 8th meeting minutes. All those in favor, please say aye.
Aye.
All those opposed? All right, the motion passes. Next on our agenda, we would have public and partner comments for issues on the agenda. All right, hearing none, we're going to go ahead and start with a presentation from some guests today. We have some folks with us today from UK Healthcare who are here to share some information about the Empath Center. I'll let them tell you more about what this resource is, but I think it's going to be a pretty significant factor within our system for addressing mental health issues. And at this time, I'll go ahead and turn it over to Mark Woods.
Yeah, thank you so much, Jeff. Hopefully you can hear us up here. So they get it. Yep, absolutely. How about if I just act like we're going to do it? I know. I wish I had a song in my mind right now, but I don't. So yeah, appreciate the opportunity to kind of stand in front of you and talk to you about the Empath Center that we have scheduled or slated for June, I think, of this year of opening. So my name is Mark Woods. I'm the Chief Nursing Officer for Eastern State Hospital at UK Healthcare. And my colleague, Dr. Lindsay Jasinski, have been sort of the two that have been tightly sort of guiding this project that has taken us quite some time. So hopefully you'll see some of the benefit. Before we get started, though, I want to kind of talk a little bit about what Empath stands for. It's the Emergency Psychiatric Assessment, Treatment, and Healing Center. So when you hear Empath, it has a much longer name for sure. Next slide. A little bit of a history of Empath Centers. I think once you hear this presentation, you may walk away from it and explain it to someone else by saying, oh, it's a crisis stabilization unit or it's a crisis center. And while that would be true, we would posit that it is a little bit different. There are some nuances that we hope that you take away from this as we go through it. This map represents the number of Empath centers across the country that are currently open, and the states that have an Empath center is the green states, and you can see in the center there, this would be the first of its kind in the state of Kentucky. And what makes it unique is that it's the first of its kind that's sort of sponsored by a hospital system. And the goal is not to stake a claim and say, we are the first and we are the only and we are the best. It's to create a model so that other hospitals across the state are able to point to that and say, oh, wow, we can do that too, and we should do that too. So hopefully that's what you'll take away from some of this. I would also mention that this model that we're going to be talking about today is seen by one of the hospital sort of governing agencies, the Joint Commission, many of you are familiar with them, they see this as essentially a best practice. And so there's been a lot of articles written on it as well. So lots of support from Joint Commission as well. Next slide. So this model started in California. You probably noticed there was many of these in California. And that was just simply the person that lit this on fire was a Dr. Scott Zeller. He's widely seen as the preeminent expert on emergency psychiatry. And when he opened up, or he kind of like started the first one, they called it the Alameda model. And many of you may have heard of the Alameda model. Alameda County is why that in California is where it first started. And so from that, he has sort of created this a different version, the empath model, over the last couple of decades, and it's governed by these 6 goals for emergency care: excluding medical etiologies and ensuring medical stability. And what that is saying to us is it's not a medical model. It's more of a behavioral health, sort of psychiatric model from the get-go. For the most part, our patients, psychiatric patients, are oftentimes taken to the emergency room. And I think if you were to kind of distill all of his different elements that you see here on the screen, I think you would take away from that the fact that he acknowledges that EDs are one of the worst places for psychiatric patients to go for a crisis. For a medical crisis, sure, but for a psychiatric or behavioral health crisis, absolutely not. And that's what this is sort of getting to. So he has these 6 models of care, or 6 sort of goals. Rapidly stabilize the acute crisis. What we know, if they go to the ED, though, some of our patients stay there for days and weeks upon time. Avoiding coercion. This model, they very rarely is seclusion, restraints, and PRNs used in this coercive sort of mindset. When our patients go to the ED, though, that is what they sort of encounter. Treating the patient in the least restrictive setting is the 4th element. Dr. Jasinski will talk a little bit more about that, what the settings look like, very open. The goal is also, number 5, to form a therapeutic alliance. When our patients go to the ED, when our behavioral health patients show up at the ED, they're met by a medical nurse. They're met by a medical physician. They're not met with someone that has a skill set that kind of tailors to communicating with patients with behavioral health needs. And so in this setting, that is what they would be met with. And then last but not least, formulating an appropriate disposition and aftercare plan. In other words, getting them connected to the next step in services. Next. So a few other things, and then we'll let Lindsay take over and really kind of drive home the model. So with this model, we know that why this model? We've got a lot of research that tells us when we use this model, 75% of these emergencies can be stabilized within 24 hours. And so that's why this model is a 23-hour bed, sort of observation bed model, if you will. And again, I think that's probably one of the biggest benefits to this model. When they go to the ED, they're either admitted or they're not admitted to the hospital. There's not a lot of attention done. If they're not admitted, there's not a lot of attention to what happens to the patient after they leave the hospital. That differs here. So a few other pieces. So what makes Empath a little bit different is it's not viewed as an alternative destination, but it is the destination for those having a behavioral health crisis. It's also it's a no exclusion sort of mindset. So often the biggest question we get is, can someone with a substance use problem or a crisis or whatever, can they come there and be there? The answer is absolutely. Are we avoiding certain groups of people? Certainly not. What if the homeless population visits it frequently? Great. So it really has a no exclusion sort of mindset, guys. A few other pieces to mention. We've already talked about how it's designed so that the patient is met by psychiatric professionals and people who are keyed in to the needs of that individual. It's a very calming, healing, and comfortable setting. And as we know, when you go to the ED, it is everything but that. It's not quiet. It's often not calm, and it's always not comfortable in the ED. And so this will be very different. And then this has a wellness and recovery-oriented approach, whereas our EDs have sort of a medical model. All right? So I'll turn it over to Dr. Jasinski, and she can take us through the last couple of slides. And we really, when we put these slides together, we wanted to sort of have it so that it's short enough that you can ask questions and get a little bit more out of this. All right. Next slide.
So, like Mark said, I think this is a really unique model, and we're really excited to bring this forward. And it's unique in its nuance, in its therapeutic approach, in the way in which we embrace people. It is designed to be very low barrier. So why? Why did we elect to go with this? Several years ago, Mark had heard about this and said, that's something that we need. Why did we say that? Because we know we have a lot of folks who are continuing to visit our EDs, and we feel like we can do better. We can provide better services for these folks. We know that we have capacity challenges in our community for behavioral health beds, for behavioral health providers. We know that we can do better. And this allows us to fill some of those gaps that we've identified in that system. So what does this earn us? It allows us to treat people. Like Mark said, when somebody comes, if I go to Good Samaritan ED for a behavioral health crisis today, I am going to be evaluated and a decision is going to be made. Do I need to be admitted to the inpatient unit or do I need to return back home? That's a great evaluation. Our providers do a great evaluation. But what we haven't done in there is said, what if we treated this person and watched them for the next 24 hours? Things could change substantially. We give them a meal, we give them medications, we offer them therapeutic services, peer support services, transportation, connection to resources in the community. All of that wrapped up into one bow is hope. And what we're giving them is an opportunity to say, let's keep you here in this therapeutic environment. Let's do all these things. We don't have to necessarily admit you to the highest acuity service that we provide, but we can still treat you in that setting. And that's how this is different. Unlike what Mark had said with crisis stabilization, we've had crisis stabilization units in our community. The difficulty with that is they tend to be a bit more narrow in scope. So you may not be sick enough for that crisis service, or you may be too sick for that crisis service. And this is really meant to be low barrier, all inclusive, come in and we'll figure it out. So what that allows us to do is then free up those inpatient beds for the highest acuity folks. We know there's people that need that level of care, and it allows us to use those for that right level. It reduces those unnecessary admissions. We know with every admission to the hospital, there's a host of psychosocial difficulties that can come from that. I mean, we hear from patients, they might lose a job because they've had to be in the hospital for 72 hours. We can avoid that. We can help them maintain some of those pieces that keep them stable in the community by using this model. Go ahead. Or maybe not. So, I think one of the things that's important to mention, and I won't belabor this, but there is data around this model. It is an evidence-based model, and there's been lots of different studies that have shown that this actually reduces rates of incarceration in the community. It can reduce rates of homelessness. It can improve outpatient follow-up. So the number of people who continue to seek services in the community. It reduces recidivism for hospitalization, so fewer people are having to return to the hospital. Those are a few samplings, and you can see, I like the picture up in the upper left corner. That's actually the Empath Center in Minnesota. And what you can see is this doesn't look anything like a normal ED. It's very open, it's very therapeutic. There's recliner chairs. Our Empath Center has floor-to-ceiling windows in several of the spaces, and you can see green space outside. So it is meant to be a calming environment. And like Mark said, an ED is anything but calming. If you've ever been there, it's anxiety-provoking. This is actually environmentally the opposite of that. It is designed to be very therapeutic. You can go to the next slide. So what are the benefits? I've mentioned some of these. Increased access is a huge benefit for us. Reduction of mental health stigma. This is much like any other emergency service, but is designed specifically for the needs of this population. reduce incarceration, increased access to a lower level of care. This doesn't have to necessarily involve a 72-hour hold and involuntary hospitalization. We can treat folks with dignity in this setting at a lower level of care. Increase engagement and empowerment for our folks to continue to seek services in our community. And then your community gains sort of this single entry point. There are multiple ways in which someone can enter our behavioral health system. We hope that through time and energy put into this, that this will be the primary way in which people can access services, and they know they can access substance use services and behavioral health services. We're partnering with New Vista as part of this initiative. They are going to be hand in hand right next to us in the facility so that we can do that warm handoff, same day transition to services. Continue to follow up. We'll transport them to residential treatment if they need that. We'll transport them to their next place. So significant benefits for the community. You can go ahead. And there's benefits for UK healthcare as well. This is freeing up our capacity in the ED. We know that we have many medical boarders in our emergency department now. If you or I had to go into the emergency department today, there are beds in the hallway, and that's because there are capacity constraints. We can help alleviate some of that by taking these patients to the more appropriate setting. And then there's lots of benefits that are well documented for patients and families as well. This is a much more therapeutic environment. We have also a calm space for family members, and we have services that we can offer to help support those family members so that they understand what their loved one is navigating and how to navigate the system as well. And then again, that seamless transition between different levels of care. Reduce time spent in an emergency room. That's not fun for family members either. That is not pleasant for anyone. And the less time that we have to have someone who's in a behavioral health crisis in that environment, the better off everyone is. And then reducing those transfers between facilities. Right now, you might go to Good Samaritan and then the sheriff would have to transport folks out to Eastern State Hospital if there's a petition and things like that. We can streamline some of those services, free those up for lots of different things that they're needed for if we can centralize some of these things. You can go ahead. So these are some pictures of what this looks like. This is a UK healthcare facility. They're leasing space from the cabinet that's within Eastern State Hospital. So it's one of our open units right now. You can see it's kind of on the back side near our admissions area. And that tree, right behind that tree right there, is the entrance. We're in progress with construction right now, and this will be a separate entrance. So folks may say, well, I don't want to go to Eastern State. They're going to a different facility. It's a different entrance, a different location within the facility. So I hope that will help reduce some of the stigma with our hospital as well. You can go ahead.
Corresponding signage.
Yes.
That is not on that as well.
Yes, yes. And then this, I won't belabor this, but this is a diagram that shows on the left-hand side, there's multiple ways in which someone can come into empath. So there's no wrong way, right? So a family member can bring someone in. Someone could walk in the door. They could take the bus if they needed to. Our EMS colleagues could bring someone in. Our New Vista colleagues could bring someone in. The police could bring someone in. Someone might show up at another emergency department and have an identified behavioral health need. They could transfer over there. So there's really no wrong way to enter. We will take folks as they come. And the goal then is to make sure they're medically stable, move into empath, and then eventually through that, we make a decision, hopefully, that folks are moving back into outpatient services. You can go ahead. So kind of overall operations, this is a 24/7 operation. It will be staffed every day of the week. We have providers on site and will at all points in time, because it operates much like an emergency center. It is EMTALA compliant. And we utilize that 23-hour observation. So when we were actually starting to build this in Kentucky, we had to do things like get OIG opinions about this, and we had to talk with our Medicaid partners as well to ensure that they're willing to cover this. And we've talked extensively. They're excited about this because this could reduce admissions for them to the hospital and allow us to use that lower level of care. So we use quick initiation of treatment. As soon as they walk in the door, we have metrics around door to doctor to treatment time. Someone is quickly treated and stabilized. We have 12 chairs that we're starting with, which we know is not enough for our community. We know that we're going to need to grow, and that's okay. We'll continue to do that as we need to. Across the country, it's estimated that folks stay about 16 hours in an empath center on average. And then this is an open therapeutic milieu, so it's a wide open space. The nurses' station is wide open as well. The entire facility, bathrooms, everything meets behavioral health standards. Why is that important? Because in an emergency department, many times we have to put folks on a one-to-one or a sitter when they use the bathroom or when they go down the hallway. We don't have to do that in this environment, and that's really important for trauma-informed care. Someone can use the restroom independently because it is a safe environment. It sounds like a small thing, but that is a really big thing. And then again, we're partnering with New Vista to operationalize, and others, working with lots of community partners to operationalize that really warm handoff back into community services. And then I think our last slide is just a quick overview. So where are we? Renovations are underway. They should be done in May. We look to be on track. It's not really a substantial renovation to the facility, and we're operationalizing all the other pieces that go with it. So all of our positions and our policies and all of the work that goes around that. Because this is a new operation, we've had to sort of work to make sure that we are in compliance with all of the Kentucky regulations and regulatory standards and things like that. And we're very excited to get this going. I know Lela has continued to work with us as well, and this is just, I think, a really great opportunity for our community, for us to do something different for folks that we know deserve the best level of care that they possibly can get. So with that, I think we'll take questions if anybody has any. Yeah. Mm-hmm. Yeah. 18 and over right now, but we are starting some conversations about what it would look like if we were to use this model with adolescents as well. So this particular facility is 18 and over. Great question. Yes, yes. Absolutely. Absolutely. Yes. You're welcome. Other questions? Yeah.
I remember back in the day, CSU used to take one off Newtown Pike before it moved down Buckhorn. So this is almost the same setup.
It is
but
different.
Different though.
I was going to say, it is different. Mark knows more of that history. He's been around a little longer than I have.
Yeah, not too long. Yeah, it's different. I mean, CSU, I think it was Crisis Stabilization Unit, literally just that. I mean, New Vista has actually, at the time, Bluegrass, they've actually had a couple of different versions and models of this. I think they had one that was in Harrodsburg at one point, and they moved it around a bit. I think where traditional crisis stabilization units sort of get themselves handcuffed a bit is they try to, for that, they're going for that sweet spot. I think Lindsay mentioned it a little bit earlier. Sometimes you can be too sick for them, and they push you away to other places or maybe just no other place. And then sometimes you're not sick enough. And so I think one of the ways, first, this is a really a hospital-based sort of program, number one. And those, the ones that you're referring back to, I think at that time, those were more ambulatory, community mental health center sort of related things. But these are hospital-based, and essentially the focus is really just about getting you into the facility so that we could spend time with you to understand what your needs are. And it may be, I know we're talking like 23-hour stay. It may not be that long. There may be people that want to be there for 2 hours, and they're hungry, and they needed help, a prescription change, or they needed just they ran out of their medicines or something like that. It could be that simple, and the person would be there for a couple of hours even. So again, one of the biggest things for this is if you feel like you're in some sort of crisis, this is where we want you to start for us. Yeah.
Yeah, and I can add too, just to the CSU piece, and kind of a key difference. I think some of the CSU criterias are you have to have housing or placement, and so that's not going to be an issue with the empath unit. So all those psychosocial things are very much part of what will be addressed, as well as the mental health issues.
Yeah. Yeah.
I guess my question is, will this program be working with other outreach programs like this organization where we have people that are on the street that can direct them? Is EMS going to be informed of this, a police department? Because I know that the main thing is you're not going to have somebody with having a mental meltdown on the street coming to you. You're going to have somebody who's going to have a level head and the right information to get them to you. And is EMS going to forego any cost for transporting somebody? Same thing with the police department. Just making sure that, the people we tell about this or need that the most urgently are able to get to you.
Yeah, it's a great question. The short answer is yes, we've been working with them. More than working with them, they've been helping us to sort of, design and certain considerations like where they're going to drop off and what area inside of the unit will they have, what workspace do they have, and what should they have in that workspace. So absolutely, we've been working with Patrick, the paramedicine team. We've been working with, Chief Cruz out of the fire department, the EMS, and that group too, for sure. Yeah. So I don't want to answer all these questions, but I certainly can have something to do. But I think different. So we visited one in Nashville, and it wasn't nearly big enough to take on all of Nashville, right? But what they were able to do is take on their portion of patients and people, and that's sort of what we kind of hope to do, is to be able to kind of have a footprint. We know it's probably going to grow. We're going to have some very concrete processes around how we manage the chairs, because you may call at noon and there may be all the chairs are full. We can't take another person, but within 1 to 2 hours, you could see that could be alleviated because you had some people that were kind of on the next step of their journey. But I don't know if you have anything else to add to that.
I would just add, when we did some analysis around this, we felt like our community needs about 20 to 24 chairs, so about double the size what we have now, and we're hoping to continue collaborating. This is really a collaboration between the Cabinet for Health and Family Services, UK, Eastern State, everybody, and we're hoping to continue to grow that.
Yeah. The only thing I would also add to that is the success of this is it's critical that to understand that we're going to be working with organizations outside of UK, right? So patient, when they enter that 23rd hour, and let's say they still need to be somewhere, like they haven't really benefited the way we had hoped that they would benefit. Maybe they need to have some sort of inpatient a longer inpatient stay. Certainly they can go to Good Sam, they could opt to go to Eastern State Hospital, but we're also in the works of having conversations with the Ridge, Sun about this same model, so that if all the things, all the requirements are met, and that's where that patient wants to go, that's where they could go. So we're still open to working with a variety of different people and organizations in our community to make this thing work. So.
One of the things that I think comes up a lot, was it somebody else?
That's okay.
Sorry, no, go.
Charlie, yeah, it's all
Charlie,
good.
go. You're the
Sorry,
commissioner. Do it.
Presumably, this will serve people from outside of Fayette County. What sort of discharge planning is going to take place to ensure that if someone comes to Fayette County, they don't get discharged into our homeless system?
Yeah, one of the challenges we've had is trying to understand how do we serve Lexington, and we've had various conversations. You'd be surprised on a weekly basis. The people that will contact us, Nicholasville and Scott County, and how can we be a part of this? And it's like, oh man, this thing is growing too much before it's even opened, right? But I think, Charlie, to your point, one of the challenges is if somebody just walks in off the street, clearly we're going to try to get them back into the area that they live, for sure, but also wherever it is they're seeing services. So, for example, if we're working with people, that's why like some of those relationships with Sun, some of those other organizations outside of Fayette County is going to be really critical. In a larger scale, this model is seen as a regional sort of referral system. And then this is not what we are today, for sure. This is for Fayette County. That's our goal, but we know we're going to have to deal with those instances as well. Yeah.
I would just add, we have case management on site, and they will work with New Vista and our other CMHCs are aware of this. So if someone comes from another area, we will do our absolute best to get them back into services in their area. I think you're up.
Me, it's me. So I don't mean to speak for other shelter programs, but I can't imagine this doesn't come up quite a bit. So it just as an example, last week, I work at the domestic violence program in our shelter. One of the women was really having a mental health, I would say it was acute. We had her go to the Ridge, and what happens often is they'll come back and they'll go, I'm fine. And so any guidance as you all are putting this together when they're coming back to Hope Center or Salvation Army or Greenhouse 17 or whatever, on how to best triage and prepare the best aftercare. I know there's confidentiality. I know they have a right to share what they want to share or not, but it would help so much upon that release if we kind of knew the best way to continue on the wraparound. So just as the plans are being made, we would love support around that. Yeah.
Yeah.
I know Lela is not a part of this presentation, but maybe she could comment on that. I mean, I think that's an important piece of it, right? It's
Yeah.
like aftercare is not just about saying, here's your next appointment, handing it to them, but if you're living in a supportive sort of organization, it would make sense to me that we would want to try to include that group in some of that communication and education. Lela.
Yeah, I mean, I'm sure it'll look, obviously a little different from Eastern State as far as, the form, like we always send the discharge data form to the shelter so they know exactly what are the medications, what's kind of that narrative of what's going on. So I'm sure it'll be something very some similar handoff because we do want good continuity of care wherever, the person's returning to. So there'll be social workers definitely in the empath unit.
Another reason why I wanted for Lindsay and Mark to join us is also to think through, obviously there are going to be folks that are coming through this center that are going to have needs related to housing. That might be housing itself, it might be case management. And, obviously June is going to be right before we would go into an additional fiscal year. So I just want this group to go ahead and have this information so that the board membership can consider ways that we can support this initiative and how it can create better continuity within our system. But also, things like Mark and I have already had some preliminary conversations about how we can actually gather some data that helps us to understand the prevalence of homelessness amongst the individuals that they're seeing, and also moving forward, help track how this impacts those rates of homelessness. Would you all, as presenters to us, have any suggestions of ways that we can go ahead and be trying to support your work?
Oh, I sure wish I came here with an ask, but I didn't. I just think, as Jeff said, I think as you start your planning, I do know that we've got a group that's going to be starting up that sort of, we've had some smaller sort of community-based meetings, more targeted and more focused, as with Patrick Branham and the EMS and all that group. But I know we're in the process of creating a larger sort of venue or forum where we can work through some of these things and ideas, really, because we would love to be able to be a part of that solution instead of being a 23-hour facility that if you walk in the door homeless, you leave homeless. There might be an opportunity that I doubt very seriously we're going to be able to affect everyone that walks in the door homeless and create a home for everyone or a place to be. But I cannot help but feel like because we're going to be an entry point, we should be a part of that solution. And so, again, I wish I had come here with more of an ask on that part, but hopefully if you want to be a part of that larger community conversation and forum, just reach out to Jeff or myself and Dr. Jasinski, and we can make sure that you're part of those communications.
I think data is really important, though. I mean, that's a great point. I think, first I would say partnership. Second, I would say let's look at the data in our community. And let's think about, as we look at that data, how do we affect changes together?
Additional questions or comments for Mark and Lindsay?
Okay,
I do have a question. This is not, I haven't thought to ask this in some of the meetings we've had about this, but so families bring somebody in, and is there a separate family waiting area? So they're not with the whole group, it's like there's a separate area?
Yeah, it's
Okay.
it's in the front of the unit as it stands right now in the servery area is designated for family. And we actually had a conversation yesterday with some folks of how can we get educational materials and resources available for family and support persons that are in there waiting, so that they can, one of the actually things that came up is UK is doing sort of more extended QPR training and has licenses for QPR training, and that's something we could have as a QR code that family members could actually get QPR trained while they're waiting, so that they understand how to ask questions about suicidality and how to ask questions about how are you doing with your mental health today. So Narcan distribution is another thing that we've talked about to family and support persons.
Well, great job. I'm a little biased, but I know how passionate you all are about this and how much hard work has went into it, so.
All right, if there's no other questions, then we just thank you for your time and for sharing your information about this resource with us.
I'm going to be able to get this up here. Let's see.
All right, so next on our agenda, we're going to have a Data and Systems Integration Committee report. I don't know, Joy, if you're prepared to do that or if we need to help you out.
Thank you so much. Yeah, if you wouldn't mind to provide an update since I was unable to attend.
All right. Do you already have something prepared? Okay.
So the Data and Systems Integration Committee met on December 6, 2023 at the Don Ball Campus Center. We moved to approve the previous October minutes. For new business, we discussed the 2023-2024 HMIS Data Quality Plan. We included updates for timeframes and date ranges, also accounting for the changes with the COC APR in ESG CAPER. As many of the folks know, that has been those changes and those updates to those reports are continuing, but we believe that they should be set from WellSky, that those reports should be good to go. We will need to vote on our HMIS data quality plan. We also discussed the 2024 Lex Count methodology. Similar to last year, this year's Lex Count will occur on the last Wednesday of January, which is January 31st, 2024. We will be asking volunteers, including everyone in this room, to please volunteer. Make your own teams of about 3 to 4 individuals and then sign up. You can do so at our website at lexendhomelessness.com. It will be right there on the front page where you can sign up your team. You will have a 35-minute training that will go over the Lex count, what it is, what the COC is, and what to do on the actual night of the 31st. We have one more meeting regarding the Lex count before the actual 31st, so we are excited about moving that along, moving that forward. We will need to just vote on our methodology. Some changes regarding this year are around our youth count. TC, I know that you have come in, so thank you for being here. In connection with TC and Fayette County Public Schools, the Lex count will be asking about additional information pertaining to those who may be fit into that McKinney-Vento definition, as well as those who fit into our definition of homelessness that is relevant for HUD as well, so that we can have both of those information on the exact same night. Other continuing business, we discussed the housing triage system, our by name list report, and HMIS training is ongoing. You would still need to seek myself regarding that training. The next training will be in February of this year, so please let me know if you need that training. We also discussed our end user group, which occurred yesterday. We discussed the housing inventory count You will all should be receiving an email regarding that today following our Lexington meeting. So if you have any questions, please reach out to myself. And our next meeting is going to be February 7th, 2024, and that will be at the East Side Branch, Lexington Public Library. So I just want to reiterate that it's happening at the East Side Branch, Lexington Public Library. I also would encourage a lot of folks to be in attendance for that meeting because we will be discussing coordinated entry and our move to a different acuity assessment in connection with our coordinated entry. So I'd really encourage folks to be there. And now we need a vote on our items.
All right, so both of these items are going to be a board vote already approved from committee. So first on the 2023-24 HMIS data quality plan, are there any questions or potential revisions that are needed? Hearing none, do I have a motion? Thank you. Is there a second?
Second.
All right. Now for a board vote on this item, all those in favor, please say aye.
Aye.
All opposed? The motion passes. Additionally, our 2024 Lex Count methodology, would there be any questions or potential revisions needed on this document? Hearing none, do I have a motion to approve?
Approve.
Okay, TC moves. Is there a second?
Second, I'll second. Whoop, second.
Thank you, Bruce. All those in favor, please say aye.
Aye.
All opposed? The motion passes. Next on our agenda, we're going to have a program performance and evaluation committee report from Councilmember Liz Sheehan.
We had our committee meeting on December 13th at the Donbaugh campus. We had a vote to approve the calendar that will also need to be approved by our board at the start of the meeting, as well as passing our October meeting minutes. We had presentations from Arbor Youth Services on their rapid rehousing for youth program. Some of the discussion at that presentation was around how they make referrals for medical services for their clients, and then also some questions about like their data entry process and how some of their percentages were calculated for the data they presented to us that day. Then we had presentations from Mountain Comprehensive Care. So the first was the Bluegrass Region Permanent Supportive Housing Program. We talked with them at the end of their presentation on some data quality questions for like length of stay, and then some contributing factors for who was staying longer in their program or who it was harder to acquire a unit for. So things like criminal status or disability status. And then we talked about income generation for clients as well, like helping them with SSI applications, their community integration supplement, and some of the job programs that they work with. Their second presentation that we had from Mountain Comprehensive Care Center was their rapid rehousing program within Lexington. Some of the discussion at the end of their presentation was around serving high-need clients and how that impacts performance when we're having these presentations and giving data back. Then talking about some of the specific kind of cases that might have had higher barriers for particular individuals. Our next meeting is February 21st, and that will be at Eastside Library as well. And we will have presentations from Community Action Council and the Lexington Fayette Housing Authority. Then we also need our board vote, so I'll turn it over to you for that.
Yeah, so we approved at the last committee meeting the evaluation schedule for calendar year 2024. There was one revision needed on that document to remove a program that has come to an end. Otherwise, we would be seeking a motion to approve the schedule.
So moved.
Thank you, Lola. Is there a second?
A second.
All right. And all those in favor? All opposed? The motion passes. All right, that brings us to our Advocacy Issues and Programs Committee report. We'll turn it over to Bo Revlett, the chair of that committee.
Great, thank you. So we met on December 20th. First thing on the agenda was recruitment of new COC partners, and we discussed using an advocacy meeting specifically as a forum to invite new partners in. And I believe we discussed doing that at our February meeting. Is that correct, Jeff, that we're gonna?
I believe so. I don't have my notes in front of me.
Yeah. So I believe we will be doing that at the February meeting. So if anyone knows any folks you want to invite to be a part of the COC, direct them to the February 28th meeting of the Advocacy Committee. We also spent a good chunk of time discussing funding priorities for fiscal year 24-25. This upcoming fiscal year, we will have more funding because of the switch from council from a set amount to a percentage of the fund balance. And so this upcoming fiscal year, we have an additional $750K. The discussion was very generative. There was discussion of a flex fund program for diversion efforts, of other prevention of homelessness efforts, spending some money on case managers, talking about how we could use funding for birth certificates since we already have a pathway for IDs but not for birth certificates, discussion around landlord recruitment and incentives. There were also ideas about are there ways that we could use the money for affordable housing or ways to fund services paired with affordable housing fund projects, and discussion of having some kind of centralized shelter bed or resource locator, like a call center or website or something. And then the next thing on the agenda was a report on council's ongoing consideration of a ban on source of income discrimination. The most updated information that I have on that is that it is likely to be considered at the January 23rd Social Services and Public Safety Committee meeting here in a couple weeks. And the last time before that committee meeting that one could give public comment on it, public comment before council, is January 18th, next Thursday. And that the shortest timeline, if it moves out of committee on January 23rd, there would then be 2 readings. It would then go to a work session and then move out of work session at some point. And then there would need to be 2 readings at a council meeting. So the most accelerated timeline would be that it would pass sometime in mid-February. Then there was a report on the lived experience engagement subcommittee. Marissa gave this report. There was a meeting on November 15th at the library that talked more about what that committee would look like going forward, and also talked about some about the coordinated entry process. There was discussion there about moving that subcommittee toward broader quarterly meetings that are more forum-based and where there's a lot more intensive recruitment, and also discussion about the fact that we want to continue to compensate people to attend those meetings. And so there was discussion about what types of compensation people are most interested in. And then we also had discussion on program standards updates. There was a standards review on the rapid rehousing standards, and at the standards were approved out of committee, and there needs to be a full board vote on that today. And then we got a report from Jeff on IDs for those experiencing homelessness. We had allocated about $1,200, encumbered about $1,300, but under $600 of that was spent. At that point, 30% of the issued letters had been redeemed. And we were still experiencing some problems with participants, making sure to get participants' legal names on the documents. And then the last thing on the agenda before public sharing was National Homeless Persons Memorial Day, which was happening the following day on December 21st. I did not get to attend, so if someone else wants to share how that was, please do.
Yeah, so we did have a decent turnout for our first event. We had quite a lot of support from the board and membership. Definitely next year we would like to see a higher number of persons with lived experience. We did get some feedback from some participants with Recovery Cafe when offered by their staff to attend. Their first question was if the event was going to be outdoors, and when we said yes, they were no longer interested in attending. So we had moved initially to hold that event outdoors with the kind of notion that is a reality that some of our participants face, and we wanted to make sure that we drew attention to that on kind of a symbolic level. But perhaps next year, with some input from folks with lived expertise, we may elect to go a different way. But I would like to thank all of the individuals and organizations that supported that effort. We had several council members attend. We had a lot of coverage from the media. We really appreciate everyone, Bluegrass Care Navigators, Recovery Cafe, the Rescue Mission, UK Healthcare, and all the other organizations who supported that up Greenhouse 17 right here. We really appreciate you all.
Great. And then the last thing from the advocacy meeting was that Diane brought up, and then Jeff elaborated some more on the Safer Kentucky. During public sharing, we discussed the Safer Kentucky Act that is before the state legislature that has a lot of anti-homelessness provisions within it. They including like bans on street camping on public streets and making it easier to prosecute homeless people for existing in public. And so this Safer Kentucky Act is one of the state legislature's top priorities in passing this year, and there are a lot of that language is still in there, and Jeff shared a little bit about the KHC, HHCK, Louisville Homeless Coalition, and LFUCG had been doing some coordinating around it. So if you want to share more on that.
Yeah, I was planning to give this a little bit later, but it seems to fit naturally here. So that bill was actually officially filed yesterday. That's House Bill 5. So the three continuums met this morning just to make sure that we are all pulling data that we want to include in our talking points consistently, so it would all kind of represent the same measures. And we're going to have another meeting tomorrow morning for all of our leadership to consider what talking points we want to align on. Definitely, we will be coming back to our membership with steps that can be taken. For those of you who are not familiar, we will send out an email including the draft of the bill. I did bring a copy with me today just to kind of go ahead and point out a couple of items. When you receive that, or if you've already got a copy, you'll mostly be zeroing in on the sections beginning on page 13. Some of the things that are of most concern, as Bo mentioned, there would be a statewide anti-camping ban, and local governments will be required to follow that, and for example, would not be able to discourage peace officers or courts from enforcement of that. That would mean that individuals that are camping in public or private spaces that are not intended for habitation would be at risk of facing charges. The first offense would be a violation with a Class B misdemeanor for the second and each subsequent offense. Coupled with this, there is some concerning language. Oh, and I should mention, camp facilities would also, per this document, apply to vehicles. So this was something that would have a significant impact. Additionally, coupled with this, there are some provisions or language that authorize individuals to use force against persons that might be camping on their property and who have been asked to leave and do not comply, including even some provisions where use of deadly force would be authorized. Beyond that, there's also language that is included that appears to restrict local government's abilities to award state and federal funds to programs that do not require participation in mental health and substance use treatment. So essentially, this would be in direct opposition to the Housing First model. So we have a little bit of a conundrum where HUD and the federal government is strongly encouraging and in many ways requiring us to operate on a Housing First model that does not require that participation. And here we would have a state measure that would restrict that ability. So one of the major areas that we plan to develop talking points is around the impact that would have in terms of dollars, units, and persons currently being served with assistance funds. But also we're going to include some information about the fact that Housing First does not mean housing only, including some data around the success rate of our Housing First programs. So some things that you can anticipate. We will share some of those talking points with the continuum. I know that some media has already been reaching out to some of our members for comment. That would just allow you to have some things that you can easily access for that purpose. Additionally, kind of like some previous legislation, we will work to develop a social media toolkit, including some graphics and pre-baked posts that individuals and organizations can use on their social media to express their opposition of House Bill 5. I'm sure that we'll probably also be releasing some things in coordination with the other continua about things like how you can contact your representatives and petitions that can be signed to show our opposition to this. So I encourage you all to make yourselves familiar with that act. There's a lot in it that is concerning for our state and a lot that is concerning for our population specifically. I'll give it back to Bo.
Yeah, that's the end of my report.
All right, then do we have a motion regarding the rapid rehousing standards?
So moved.
All right, is there a second?
I'll second.
Thank you, Bruce. All those board members in favor, please say aye.
Aye.
All opposed? That motion passes. All right, I'm next with a encampment SOP and review report. This is going to be actually a short report for us. We only had 2 encampments that have been cleared by LFUCG since we would have last met. One of those was a routine check of an emphasis area. There was no active encampment found there, just some debris that was removed. Since that was an emphasis area and a routine cleanup, there was no notice to this office. That cleanup was conducted on November 15th at a cost of $500. The next location was a camp in the Man of War Sarin Drive area. This was notified to the OHPI by police on October 19th. We initiated attempts at making contact that day. We did have contact with one individual who had communicated plans to access shelter. He had requested a little bit of additional time to get some of his belongings into storage with a friend or family member and had requested some assistance with transportation from outreach to get to shelter. Unfortunately, that did not occur. We lost contact with that individual, and you're going to see there's a lengthy period where there were a lot of subsequent contacts attempted, and that represents there was a delay with our environmental services team being able to get out and perform the removal of that encampment due to things like leaf removal that were going on at that time. We wanted to make sure that we continued those periodic checks to ensure that we were able to provide adequate notice and reconnect services with that individual should he reappear. First notice was posted on November 7th when we had a tentative timeline for cleanup, and that final notice went up on November 28th with cleanup being conducted on December 6th. This was a very significant cleanup with a cost of $3,100. That brings our overall fiscal year to date total of encampment costs to just over $36,000 with 12 unique locations and 16 total cleanups. And we continue to have around a 50% success rate in getting engagement in services. Questions or comments regarding the encampment report? All right. Hearing none, we'll move into the OHPI Director's Report. The first item related to this in your packet is going to be an update on the budget. So our fiscal year 22 funds, which of course were rolled on to ARPA funding, are just about closed out. We had previously decided to spend some of our 24 funds for lived experience engagement, compensation for individuals participating in those activities. I went ahead and shifted some of that cost to 22 so that we can try to go ahead and close out this ARPA grant and not keep it open longer than necessary. So right now we have around $300 that's going to be remaining, and that is for the purpose of state ID assistance. You'll also see highlighted in this table the remaining amount from our racial equity analysis. That is the amount that our board had voted to put towards operation of our temporary winter shelter operated by the Hope Center. Highlighted that so you can see the movement. It was transferred through a budget amendment to the budget for the winter warming shelter. Next, for fiscal year 23, also rolled on to ARPA funding. Many of these programs have already come to a close. We still have some funds remaining with our payee program. Again, we would have plans to transition that to community and resident services. Danielle Sanders and myself have had some preliminary meetings with Welcome House on that transition and are working on all the steps to smoothly transition those individuals to community and resident services case role. And then we have the onboarding curriculum that is still expending funds. Many of you are participating as subject matter experts in that project, and we appreciate your support. We have several modules that are in process, and pretty soon we're going to be scheduling some time with some of our providers to do some on-site filming of some footage and some pieces to be incorporated into that curriculum system. So short of those projects, we are going to have about $598 remaining, which was the balance left over from our HMIS subsidy. Then fiscal year 24, the final year of funding for this office that rolled on to ARPA. We've kind of just barely gotten started on this one. We, of course, have paid out our HMIS subsidy for this year. We have already funded Street Outreach 3.0. I just got and processed the first couple of invoices for that project, but not until after I had released this packet. We had also committed some resources for our winter response, including the Bluegrass Care Navigators Program and the Community Action Council Family Motel Shelter Program. And so that leaves us right now with an amount of about $160,000 that is remaining on the original $750 that was committed for the fiscal year. And then, of course, we did receive an additional $750,000 from the fund balance. So I went ahead and created a separate table down below to reflect the funds that are actually true general fund dollars. So far, we have committed a small portion of that to New Life Day Center, and we would have the additional $750,000. We have a $19,000 and some change rolling balance that was brought forward when we funded New Life. And then we have the money that was recommended by Councilmember Worley to conduct a shelter and transitional housing feasibility study. Charlie and his office and myself have worked on drafting that RFP, which will go back to committee for review before it is released. But that study is intended to help us understand what our shelter and transitional housing needs are, but also recommendations for how we might potentially implement additional shelter or transitional housing resources. Any questions regarding the budget update? All right. Then next, we had at the last meeting approved our 24 meeting schedule, but we had a couple of committees that we were still trying to find a home for. So as a formality, I wanted to bring that back to the board for approval with the full details. We are now going to be hosting the Data and Systems Integration Committee, as well as the Program Performance and Evaluation Committees at the East Side Public Library. And then the Advocacy Issues and Programs Committee will remain here in this, actually, it will be at the Don Ball Campus Center. The only meeting that's going to remain in this space is going to be our board meetings, and we do have 2 dates that this space is not available. That's March and September. Those months we are going to meet in the council chambers, which is on the 2nd floor of the Government Center. Try to include asterisks there that would help identify that there is something that is different about that meeting. Also on the agenda for today's meeting, I put in bright green the meeting date and location for next time, and you can be quite confident that I will bold, underline, put in red when I send out the reminder email. And I apologize to whomever inevitably shows up here instead of the council chambers. Thankfully, it's a short commute for you. Can I go ahead and get a motion to approve the 24 meeting schedule with the added details? TC gave a motion. Is there a second?
Second.
All right. All those in favor, say aye.
Aye.
All opposed? That motion passes. All right. Next, you will recall that we recently revised our governance charter to try to more fully bring us into compliance with HUD regulations. Language within that governance charter stated that we would readopt that governance charter in January of each year, as well as our officers. So presenting it here, if there's any discussion, we can partake in that. But ultimately, what I would seek would be a motion to approve the governance charter with the existing officers for the next year until we would vote again in January of next year. Any questions or discussions around the governance charter? All right. Hearing none, this would be a full membership vote, so anyone in the membership would be able to make a motion. Is there a motion for approval? All right. And do we have a second?
I'll second.
I'm sorry, who was that? Thank you, TC. All right. And again, full membership vote. All those in favor, remember this would be one vote per organization. All those in favor, please say aye. All those opposed? All right. That motion passes. All right, and in this marathon stretch of talking, the last item that I wanted to have that's actually not on the agenda kind of popped up unexpectedly. And so I wanted to go ahead and provide you with a little bit of an update as to where we are at with our winter response. So as you know, we funded as our primary resource for this year the temporary shelter with the Hope Center. For those that are unaware, that is operating at 381 West Loudoun Avenue, and that's on the campus of the North Lexington YMCA, serving adult men and women, also able to accommodate pets. Some information to let you know how things are going. So far, I've only processed one invoice, so I don't have any concerns at the moment about budget. Should that change, we'll obviously come back to this group. But right now, I can share that we've served 496 unique individuals, including 338 males, 158 females, and over a dozen pets. Since we opened on November 22nd, there's been an overall average of 116 individuals served nightly. And since we do see some trends related to the weather, I can also share that the average over the last 7 days was about 151 individuals. So that obviously brings us very close to our standard capacity of 160 individuals. So we are continuing to communicate with the Hope Center to look at how we can surge that capacity as needed, looking, for example, at the forecast over the next week or so, knowing that next Monday evening we're going to be looking at a low of roughly 6 degrees. We're working with them to make sure that there is an adequate availability of beds for those that are in need. We also have updates from our other resources, the Bluegrass Care Navigators program that is doing short-term hotel stays and basic needs for individuals that are senior and disabled, has already served 16 unique clients to date, and they've already exited 8 of those clients. I learned that we filled another space today, so we are just under our capacity with that program. So far, it is on track financially. And then Community Action Council, we had awarded some funding to operate some motel rooms to expand their emergency family housing program, which typically uses apartment units. This is one that Councilmember Sheehan, as chair of the Program Performance and Evaluation Committee, had specifically requested that I keep you guys informed about. We're probably going to need more money on this one. So, so far, hotel costs alone through the end of December ran about $25,000. The overall commitment that we made at the onset of the winter, with the caveat that we may need additional funds, was $48,500. The program has served 14 families so far this season. They're doing their best to rapidly move families to a more permanent situation. Doing really well with that, but we still have needs that are popping up, especially when we're experiencing the weather conditions that we are presently. At the moment, we have 7 families that are currently in hotel. So I would like to go ahead and inquire with the board now if you would like to go ahead and make an additional commitment. My rationale at this point is we've already gone through about half, a little more than half of the money that was committed, and we still have the remainder of January, February, and March to go. So I would definitely recommend that we consider making an additional commitment today so that I have some time to go ahead and work through the administrative processes associated with upping the amount of funding, and make sure that there is no gaps and no concerns on community action's part about being able to continue to operate whenever they have a need that arises. Based on the fact that we are this far into the funding, I'm going to say that we probably need to look at committing an additional 25 to 40,000, and then we would also have an opportunity at the March board meeting, and we'll be very close to end of operations at that time. If they have somehow exceeded the additional amount, then we could consider bringing that up to cover their expenses for the remainder of the season. So I don't know if any board members feel compelled to go ahead and make a motion, or if there would first be some questions or considerations. I'm open for discussion.
Okay, I can comment on the support that we are getting through the McKinney-Vento, because we still have so many families that are struggling out there. This past week, I've had a family that's been in an abandoned church with no electricity. I've had a father and his child in a truck. So, I mean, it is a great need for us to have that as a winter backup plan for our families, that, because a lot of times when I call the Salvation Army, they're busting out of the seams. And so, but we have to make sure that our children are not out in the elements. So I'm going to the highest of the amount, $40,000. If we don't use it, then that's good, but it's there in case we need it for our kids.
Thank you. And I'm definitely open in terms of the amount. I just wanted to give you guys my opinion of kind of a ballpark of where we needed to start.
Is that a motion, TC?
But if that's what it takes, yes, it is.
Okay. Then I would second her motion to go ahead and go to the $40,000 on this.
All right, so this would be a board vote. The motion on the floor is to go ahead and commit an additional $40,000 for Community Action Council's winter motel funding. All those in favor, please say aye.
Wait, can I add
Yeah.
to that really quickly for discussion? I would also amend that motion to say that we could have further discussion if new expenses arise and it ends up being over 40.
Thank you.
So that's
So
my
the
motion for
amended
the
motion
amendment.
on the floor then is the 40,000 with the ability for us to come back and commit additional funds as needed.
Second.
All those in favor?
Aye.
All opposed? Didn't think there'd be a lot of opposition, so I appreciate that. That motion passes. All right. Next, I had planned to give an update on House Bill 5, but we already covered that. I will definitely share that bill via email following this meeting, so you can go ahead and familiarize yourself. Again, I would focus in on the sections that start on page 13 through roughly about page 17. That's going to be the bulk of the items that we are concerned about related to anti-camping provisions, as well as restrictions on our ability to fund Housing First programs. I will note that there are other sections of that document that you may want to take a look at. There are some concerning things related to things like rental damages and the responsibility that would be shifted to tenants, and some other things outside of specifically the area of homelessness. The original bill was 68 pages. I think now it's expanded to something around 74. Just a little light reading. But again, pages 13 through 17 are probably going to be of most interest to this group, and we'll share additional details about how you can advocate against that bill. At this time, we'll go ahead and announce that our next board meeting will be in the council chambers, not here. Council chambers, Government Center, second floor. Just check in with security and they'll direct you where you need to be. And then now we're open to public sharing for issues not on the agenda. So if anybody has any announcements, updates. The next board meeting is going to be March 13th. 1:30 to 3:30, and the Government Center is located at 200 East Main Street. Again, we'll be in the second floor in council chambers. No, yeah, go ahead.
I would just like to add, as far as our advocacy on House Bill 5, I kind of feel like everybody in this room probably would be advocating on those points, but as you're talking with different populations, another point on that is also the unnecessary police involvement that's included in something like that, and the opening up of additional lawsuits. We've seen multiple overuse of police force with removing homeless people that have resulted in huge liabilities to the city and counties where those incidents have taken place. Again, that's not what sways me or probably any of us in this room, but as you're advocating with different populations and people from different backgrounds that may not be as sympathetic to the homeless population and to the concern about police involvement, on the other side of that is also the liability and money on that side of things.
Thank you.
Also, I'm going to be hosting a community table talk at the 450 Park Place on January the 26th from 8 to 11. Any community partners that would like to join us, please let me know if you would like to come. I'll make sure you get the direct information. The agenda is to basically talk about what we are doing as community partners, because the last time we hosted it was a lot of times we don't know what services we all are providing. And so we realized too that we were all kind of overlapping services. So it was good that we came to the table and we actually talked about it. Currently, I have a lot of high schoolers. I have over 200 high school students that are McKinney-Vento, so we need to ensure that we are making sure that we connect them with community resources and services, so when they graduate from high school, their services drop off from Fayette County schools, but we need to ensure that they know where the community partners are, so when they do get in trouble, we don't want them to repeat the cycle. So we definitely have to educate our young people on how the community is coming together to help and support them. So if you would like to, let me know if you would like to participate with that.
And if you want to shoot an email, if there's a flyer or a blurb, I'd be glad to send that out to the listserv.
Okay.
Anybody else have comments? All right. Thank you very much. We hope to see you on March 13th, and hopefully several more of you in our committees in between. Do we have a motion to adjourn? TC has called it. Thank you.
If you did not sign in, please sign in. Thank you.